Like Cindy said, my name's Henry Lin. I'm a pediatric hepatologist at the Children's Hospital of Philadelphia, trained under Dr. Piccoli and also Dr. Bales as well. As you might have noticed, I'm giving on an organ system that's not quite the liver, but rather the heart. But the interesting thing is that we do think that the heart and liver are actually quite connected in many facets. And actually, if you talk to most hepatologists, I think will all tell you that the liver is just maybe a little bit more complex and more important than the heart. Although we will say for the cardiologists, if there are any in the room, that yes, the heart does pump blood to the rest of your body, so it is important, but it's basically plumbing. The liver requires a little bit of higher order thought. So, let's see. I think we've heard a lot about Alagille syndrome already. That initial picture right there was of Dr. Alagille himself. We'll skip over the basics, but what I really want to focus on for the cardiac talk is to try to make it a little bit more interactive, if you will. I think the challenging part when we talk about the different organ systems that are involved is that there's such a wide variety of presentations, and that's especially true in the heart. What we know about cardiac disease is that if you look at the table here is that over 90% of people with Alagille syndrome have some form of cardiac involvement. And in the 5 big studies that we always cite, the heart is involved in up to 96% of people. So what does the heart do? I made a little slight to the cardiologist that it's just an organ that pumps blood, but in reality it is obviously very important. What it does is obviously it takes the blood that returns after circulating from your body, and it goes from, pumps it into the right side of your heart, and it goes from the right side of your heart where it's deoxygenated, or really lacking the oxygen, and actually then goes up into your lungs where the oxygen is replaced. You get more oxygen into your lungs, and then goes into the left side, and from the left side out to your body where it can deliver the oxygen to the rest of the body. So while it seems very simple, if there's any sort of holes or any sort of structural defects, it can actually make the entire cardiac process a little bit challenging. So when we're talking about cardiac manifestations in Alagille syndrome, like I said, over 90% of children with Alagille will have a heart defect, and the severity of the heart defect varies. Some people can have just a simple murmur, and some people can also have a fairly significant major structural heart defect. Most of the heart defects involve the pulmonary arteries. So again, the pulmonary arteries are the blood vessels that actually carry blood away from the heart into the lungs so that it can be oxygenated. So what do we know about, why is the heart with Alagille syndrome? And I think we should take a step back and think about the genetics behind it. Clearly we've heard a lot about the Notch signaling pathway and how JAG1 is one of the main genes that are implicated or is implicated in Alagille syndrome. And if we look at it, we actually see JAG1 mutations in other individuals who don't have Alagille syndrome but actually have cardiac defects. In one of the first reports of a JAG1 mutation was actually in an individual with pulmonary stenosis and Tetralogy of Fallot. And what I'll do is I'll go into both of those disease processes in a little bit more in-depth later in the talk. But that just goes to show that both of these defects can actually be seen in people with Alagille syndrome as well. And so clearly there must be some sort of interplay between JAG1 mutations or Notch signaling pathway and the cardiac manifestations. In addition, following that first case report of a patient with a JAG1 mutation who had Tetralogy of Fallot and pulmonary stenosis, we've now identified JAG1 mutations in a variety of patients who have Tetralogy of Fallot without Alagille syndrome, and even in other syndromic diseases, if you will. So there's a group of people who have familial deafness, as well as congenital heart defects and posterior embryotoxin, which is actually quite interesting because if we look at that, those are actually 3 features that we do see in Alagille syndrome as well. And but yet, this cohort of people that we've studied they do not have Alagille syndrome. So again, closely showing the interplay between the notch signaling pathway and the development of cardiac defects. So like we've heard in some of the talks beforehand, your genes are, while your genes are encoded in all of your different cell types, they're only expressed in certain cells, and especially when it comes to JAG1, the question is that gene expressed in the cardiac cells? And so we actually have a really nice that was done by our colleagues at Children's Hospital Philadelphia, looking at JAG1 expression both in the mouse and human hearts. And so if we take a look here, let's see. So if we look at this picture here, this is a sample of a mouse fetal liver who we've essentially knocked out JAG1. And what that means is they actually have a JAG1 deletion, so very similar to we would expect to see in people with Alagille syndrome. And what we did was we stained to say, let's stain for the JAG1 gene product, which is actually denoted by this yellowish greenish stain right here. And you can see that it actually highlights a lot of the structures. The AT actually is the atria, the VT is the ventricle. The atria are the two chambers up top, the ventricles are the two chambers in the bottom. So basically what this is showing is to say that even in the fetus of a mouse, you certainly see JAG1 expression in the different structures. So we think, oh, great, that's wonderful, but how does that relate to us? Certainly we're humans, we're not mice. And so we said, well, let's take a look at what it looks like in human cells. And indeed, we well. So again, here's your ventricles. This is A stands for the aorta. These are your coronary arteries, which are the blood vessels that actually supply blood to the heart. And then there's the AT for the atrium. So again, just showing that we do get staining or JAG1 expression in fetal hearts as well. So now that we know that JAG1 is expressed in the heart, then the question is well, what role does it play in this development of cardiac disease? And so if we take a step back and say JAG1 is integral in the notch signaling pathway, what we do know is that the notch signaling pathway plays a role in the development of cardiac defects. Specifically, it's involved in the formation of your ventricular septum. So what that is your ventricles are your two big chambers of the heart that actually pump blood out, either out to the body or out to the lungs. And there's a septum or a piece of muscle that divides the two of them. And so during early cardiac formation, the notch signaling pathway plays a big role in helping to make sure that not only that the septum forms, but also other parts of the heart form appropriately, including your heart valves and as well as your blood vessels as well. We've also shown, or we also know that JAG1 is actually very important in mediating the cell-to-cell interaction, or how the cells talk to each other during early cardiac formation. And in fact, we know that in people who lack one functional copy of JAG1, that you can actually see abnormal development of the heart. And what's even more interesting is that it's not only limited to JAG1 itself, but really some of the downstream effectors of JAG1. So meaning that in the whole pathway, it's not only JAG1 which kind of sets off this pathway in motion for development, but any of your downstream receptors such as the different proteins are also integral in the development of other cardiac structures. So this here is another way to really highlight what's the role of the JAG1. So this is a mouse model of Alagille syndrome, and what we can see here is clearly here is a normal mouse versus a mouse in which we've recapitulated the Alagille phenotype. So essentially, you can see a little smaller. I can't tell if you can appreciate the jaundice or the yellowness in color, but so clearly showing that when we try to genetically make animals that allow us to study the effect of Alagille syndrome, we can make some of the phenotypes here from some of the obvious clinical features. And so the question is as well, if we have a mouse that on the outside looks like someone with shows some of these Alagille features, what does the heart look like? And so here, if we look at this picture on your left is the picture of a normal mouse heart, and the one on the right is a picture of the of a heart from a mouse in which we've induced Alagille syndrome from a genetic standpoint. And you can tell, number one, the heart's a little smaller, but that's not necessarily the main point that we're looking at. This, I think the reason it's a little smaller is just more from the standpoint of, potentially just the different size of the mouse. But what's interesting here is that you can tell here on this side of the heart, it looks nice and rounded, and you might have to use a little bit of imagination, but here it looks a little bit flatter, if you will. And what that shows is that ventricle, that's actually your right ventricle, so one of the main pumping chambers of the heart, and it's just not as fully developed. And again, that goes in line with what we've seen before in that JAG1 actually plays a big role in cardiac development. So suggesting that in a mouse in which it's lacking the full expression of JAG1, the right ventricle doesn't develop as well. And also here at this arrow up here, this is looking at the pulmonary vessels. And so I think a lot of us may be familiar with the term peripheral pulmonic stenosis, or sometimes the pulmonary vessels are a little bit narrowed, and that's essentially what we see here. And actually, if you look at figures B and C, it's a little bit bigger, it's a little bit magnified here to show that really here it's a little bit more narrowed compared to over in the wild type or in mice with 2 normal copies of JAG1. So I promise you that ends the basic science portion of the talk right there. But I think it's just nice to really get a sense to know, where's the research at, what do we know about, Alagille from a cardiac standpoint, and what have we been able to show? So what I'd like to do for the remainder of the talk is to really go over and review some of the key cardiac manifestations of Alagille syndrome and really talk about, how does that pertain to us and what can we do about it? Because I think a lot of times it's one thing to know, to say, okay, I have peripheral pulmonic stenosis, but really, does that impact what I can do with, from a daily activity level? Should I be worried about any medications that I can take? Can I be involved in sports? Those questions of activities of daily life, I think, are very important for us to keep in mind. And so this here is a list of 6 of the main cardiac diseases that we see associated with Alagille syndrome. Top of the list is peripheral pulmonic stenosis, which is perhaps the most common cardiac lesion, closely followed by, I shouldn't say closely followed, but Tetralogy of Fallot, which is up there, and you see the 12% next to it. Tetralogy of Fallot is actually the most common congenital cardiac defect. And what we mean by that is it's the most common structural defect outside of peripheral pulmonic stenosis. So, let's see. So to talk a little bit about peripheral pulmonary stenosis, show of hands here, how many of our children or family members have with Alagille have peripheral pulmonic stenosis? Right. So if you look around, that's probably about 90% of the people in the room raise their hands. And again, that's what we would expect. It's one of the most common cardiac lesions in Alagille. I think a lot of times when we talk about PPS, that's the abbreviation we use, what exactly does it mean? And so if you break it down, so peripheral pulmonary stenosis, so stenosis really just means narrowing, and that's all it means. And so the question is, where is it narrowed? Well, it's narrowed somewhere along the pulmonary veins, and in fact, it's on the peripheral veins, so meaning it's less likely to be on the main branch of it. So what I mean by that is, you can see here, this is right atrium, right ventricle. This goes into your pulmonary vein, and then it branches into your right and left branches. And so usually, when we talk about peripheral pulmonary stenosis, it's out here in the branches that are narrowed and not so much in the main pulmonary vein. But that said, in Alagille syndrome, we definitely do see stenosis in a variety of areas in the pulmonary veins, including both at the level of the valve as well as at the level of the main pulmonary artery. I keep on saying vein, but artery. But at the main pulmonary artery as well as the branches. I was just checking to make sure you're awake, Dr. Piccoli. But the for the part, people with PPS are generally asymptomatic. You might hear a murmur on exam, and that's about it. And for the most part, it really doesn't impact overall cardiac function. And so it becomes one of those findings that we say, oh, okay, we have a murmur. We know that it's a cardinal feature of Alagille syndrome. We attribute it to PPS, but it shouldn't impact overall quality of life. That said, if it's not peripheral, so if the narrowing is really in the main branch or at the level of the valves, that sometimes can lead to more significant cardiac involvement as well. So there are actually two difficulties. Switch gears a little bit and talk about tetralogy of flow. So tetralogy, it's, if we take a look at it, it's a constellation of symptoms. And so a tetralogy meaning four, so there's usually four main features that we think about. And so if we look here, this is the normal heart versus what does a heart with tetralogy of flow look like. And if you look at 1, 2, 3, 4, those are kind of the four features right there. So number one, it's actually a VSD, or a ventricular septal defect. And so again, this is, the septum is that muscular wall between the left and the right side, right ventricles. And essentially what happens in tetralogy of flow is that you actually have an opening between these two ventricles as depicted in this picture here. In addition, the other things that you can have is that you can actually have pulmonic stenosis, or narrowing. And if you look at this schematic, the vessel here is much narrower than what we see here over at the normal heart. And on top of that, because it's narrowed, it's harder for blood to actually pump through those vessels. And in fact, what ends up happening is that your aorta kind of takes over some of that responsibility as well. Also because of the fact that you have this opening in between your right and left side of your heart, the blood, your aorta comes in and it's automatically going to get some blood that's deoxygenated, or from the right side of the heart will be mixed with oxygenated blood from the left side of the heart. And then the fourth thing is, you actually get a little bit of right ventricular hypertrophy, or the right ventricle has to work harder. And again, the reason why it has to work harder is because blood is going to go the path of least resistance. Blood obviously wants to go up your pulmonary arteries to the lungs, but if you have a very tiny hole versus a big hole in the septum, it's going to preferentially go over to the septum instead of going up to the lungs. And so by default, your body's telling you, hey, I'm not getting enough oxygenated blood. Maybe it's because the right side of my heart isn't pumping effectively enough, and so it has to work a little harder and ends up trying to build up some muscle instead. Like I said, a little bit of information about tetralogy flow. It's the most common congenital defect in Alagille syndrome. We see it in anywhere from 7 to 12% of people who are affected, depending on the study that you look at. And what's interesting is that even in tetralogy of flow, you can actually get a range of severity of the involvement. And so some people have a little bit more mild tetralogy of flow, some people have more severe. And what we've noticed is that the more severe tetralogy of flow I shouldn't say that, or people with Alagille syndrome tend to have a more severe form of tetralogy of flow. What's this mean for us? What can we do about it? Well, one of the first things we think about with tetralogy of flow is that children are at risk for these TET spells, or basically these sudden spells in which all of a sudden you're not getting enough oxygen to the rest of your body. And the reason that happens is because, as I was showing you a couple slides before, is that you have that hole between the right and the left side of your heart, so you're basically mixing blood, and not all the blood is effectively going, not all of your oxygenated blood is being pumped out to your heart. You're actually getting some oxygenated and deoxygenated blood. So this is actually a fairly serious event in children, and when these TET cells happen, what happens is that you can have a sudden onset of someone turning blue, maybe a fainting spell, and it happens because you're not getting effective blood flow up to your lungs to oxygenate, to be oxygenated. And so the treatment, there's a variety of treatments for it, but suffice it to say, the idea is to say, what are other ways that we can actually increase flow back up to the lungs so we can continue to get that good oxygen flow? One of the most common things is that or bringing a baby's knees up to the chest, and again, all that's designed to do is to really say, let's move more blood back up to the lungs. Ultimately, with tetralogy of flow, unlike peripheral pulmonary stenosis, it does require surgical repair. Surgery usually takes place between 3 to 6 months of age, and sometimes depending on the severity of the lesion or what's affected, you may need some palliative surgery prior to the official surgical correction. So these palliative surgeries include something called a BT shunt or a Blalock-Tassig's shunt, and all these shunts are designed to do is to say, how can we transiently increase flow to the lung while the child is growing a little bit bigger so that they can do surgery. What the surgical correction actually consists of is, number one, closing the VSD, which is that ventricular septal defect, and then also trying to relieve the narrowing between the right ventricle and the pulmonary artery. And so, what exactly does that mean? I think pictures try to illustrate this a little bit better. So here is the picture of, again, tetralogy flow. Here you have that narrowed pulmonary artery. You can see the big, thicker right ventricle right here, and then obviously this opening between the right side and the left side of the ventricle. So this is that VSD. So ultimately in the correction of the surgery, they actually patch up this VSD here, and then they try to open things up through the pulmonary artery to allow blood flow to go through. Sometimes in between, depending on age of the child and the severity of the cardiac function, while we're waiting for the child to get a little bit bigger, we actually put in the shunt, which effectively allows blood to then go back into the lungs. And so what that means is, essentially here, this is your aorta, which is the big blood vessel that carries blood to the rest of your body. And if basically, since the left ventricle is pumping a lot of blood to the rest of the heart or to the rest of the body, if you kind of have a shunt or a pop-up valve that connects it back to your pulmonary arteries to then go to the lungs, it allows some of that mixed blood to go to the lungs to get more oxygen, basically. So that's tetralogy flow. Ventricular septal defect, this is a lot easier lesion to describe, especially because this is one of the lesions that we see in tetralogy of flow. Essentially, it means that you have a hole in the ventricular septum. And so again, the septum is that muscular wall that separates the ventricles. And what this opening allows is it actually causes blood to move from the left side of the heart back to the right side. Because the left side of the heart has much higher pressures because it needs those higher pressures to pump blood to the rest of the body. And so again, blood moves in the path of least resistance. So if you have a big hole here, it's easier for the blood to flow back into the right side of the heart and then go back up to the lungs than to actually go back out to the body. And so what's the result of this is that you get oxygenated blood just being continuously recirculated, going back to the lungs in this perpetual cycle. And what it potentially can do is it can limit the amount of blood that you're pumping out to the rest of your body. So how do you repair it? There's a couple different ways, but essentially what they do is you can actually take a synthetic patch and actually just put it over the defect or over the hole and just sew it in place, and voila, you've corrected your ventricular septal defect. This is one part in which I will actually give credit to the cardiac surgeons because it's a lot harder than just saying voila. So. Atrial septal defect, so that's a hole in the atrial septum, so essentially the same principle, only atria, which are the two chambers up top. Again, same principle. The left side of the heart has higher pressure, so the blood actually preferentially goes from the left side into the right side and gets pumped back to the lungs instead of going back to the body. And this is where it gets a little interesting in the setting of, you can have an ASD, but you also see these atrial septal defects in the general population. And in fact, kids can have a very small atrial septal defect that closes over time. And this is a similar feature of what we see with other organ system involvement in Alagille syndrome. So such as like with posterior embryotoxin, where we know, with that eye involvement, we do see it in up to 15% of people who don't have Alagille syndrome as well. And so the reason why I point this out is that it doesn't mean obviously you have an atrial septal defect that you obviously have Alagille syndrome, but rather if you have Alagille syndrome, you are at risk for developing some cardiac lesions, and atrial septal defect is one of those that we do see. To talk a little, so a few of the other lesions that we see, Aortic stenosis is a big one. So stenosis, as we reviewed here, is narrowing. And so aorta being the main blood vessel that pumps blood out to the rest of your body. And so really that is a typo. It should say outflow track leading from the heart into the aorta. So basically what it is that, you know, this area right here, it's a little bit narrowed and becomes obstructed. And again, it just impedes blood flowing out. The last main cardiac lesion that we see is actually coarctation of the aorta. And so what that is that's actually a narrowing. If you looked at some of the other pictures, usually you get this nice arch-shaped aorta kind of coming up and down. But in coarctation of the aorta, sometimes what happens is you get a little bit of narrowing at some point in the arch. And again, that narrowing can impact blood flow out to the rest of the body. Typically, the narrowing of the aorta occurs at the level of the ductus arteriosus, which is a vestige of cardiac development. So the question is, well, what happens here? So believe it or not, the cardiac surgeons have also come up with a repair mechanism for this as well. They're quite lovely. You know, the thought process is that, you know, if you have this area of coarctation or narrowing, can you actually essentially splice this out, remove it, and then repatch up your aorta, the aorta again, and that's what you see right there. Very technically difficult surgery, obviously. Much more difficult than in the 2 minutes that I've spent describing it. And so those are just kind of going through kind of the 6 of the most common cardiac lesions that we do see that are associated with Alagille syndrome. And so, you know, I think then that gives us a pause to take a step back and say, well, what does this mean for us? You know, what does this mean to me if I have Alagille syndrome? And so, you know, I think the heart's important in Alagille because it's one of the 2 main organ system involvements that can really impact your overall prognosis. Obviously, you know, quality of life and prognosis, clinical prognosis, it's highly variable in Alagille syndrome. And usually it's related to severity of either liver disease or cardiac disease. And actually, if you look at a lot of children who do poorly early in life, it's mainly because of cardiac disease. And in fact, cardiac disease is probably the #1 cause of mortality early in life for Alagille syndrome. And the reason for that is because, you know, if you have any of the more severe cardiac lesions, that not only impacts your blood flow to the rest of your body, but, you know, obviously it also impacts other organ system development. So if you look at the numbers in particular, you know, it's, like I said, it's a main cause of early mortality in Alagille syndrome. So the key thing here is people with an intracardiac lesion, so any sort of main lesion such as Tetralogy of Fallot, aortic stenosis. The 6-year survival rate for is been reported to be in the 40 to 50% range. For people without an intracardiac lesion, so that includes people with PPS, your 6-year survival rate is actually you know, much higher. So, you know, I think one thing that I'm frequently asked about with patients when we're talking about cardiac involvement in Alagille syndrome is to say, well, great, you know, now you've told me what lesion I have. You know, you're telling me that the prognosis is really dependent on what's the cardiac lesion, but, you know, what can I do in the meantime? Is there anything I can do to help, you know, stay healthy, prevent it, or, you know, what do I need to do to help diagnose it? And so, you know, fortunately or unfortunately, a lot of the management is dependent on the underlying malformation. You know, obviously, if you have Tetralogy of Fallot, a VSD, any of the intracardiac lesions, you may actually need surgical correction. I think the challenging part is that, you know, in some instances, you can have a ventricular septal defect, you can have an atrial septal defect, and you potentially could be fairly asymptomatic for the first couple years of life. And so the key is early detection to really help us plan clinically in terms of what we need to do. The main thing is obviously PPS, peripheral pulmonary stenosis, is usually asymptomatic, but again, something to keep in mind. And, you know, even though cardiac manifestations are a main cause of main impact of prognosis, heart transplants are not typically performed. And in fact, if you look in the literature, there's only been a handful of instances in which we've had people with Alagille syndrome who had such bad cardiac disease that they've been transplant candidates. So essentially, what we can do is, number one, we can do a cardiac exam to assess for a murmur. So what that means is, obviously, having your primary physician, take a listen, and if they do hear a murmur, then I think one of the first things to do is to get an echocardiogram or an ultrasound of the heart. And really, what that's doing is that's looking for any sort of lesion within your heart or in the peripheral blood vessels. The other thing to think about is that, if you remember that earlier on I said, sometimes even in people with JAG1 mutations, you can see different cardiac lesions and also have different features. So, if we do identify a cardiac lesion and we're saying, we're not 100% sure if this is Alagille syndrome, you don't have all of the typical features, then we do recommend getting additional genetic evaluations, because we do see other syndromes in which you can have some of the Alagille features as well as cardiac lesions. And so, I think that's the overview right there. And like I said, it's always a challenge when we're talking about, cardiac disease and, what can we do about it? Because, unfortunately, for the majority of lesions, we're limited to either surgical correction or just observation at this point in time. For the most part, if you have PPS, like we said, it's generally asymptomatic and really shouldn't impact your quality of life from a cardiac standpoint. And in fact, children should be able to do what every child is doing, which is running around, getting in trouble and playing sports. So that's our overview right there of cardiac features, and be happy to take any questions. Obviously, I was either very, very thorough or I successfully put everyone to sleep. I hope it's not the latter.